Well, thank you very much. I want to thank the organizing committee for the kind invitation. It's my pleasure to be here. Entschuldigung, ich kann nicht Deutsch sprechen. And so I'll have to cover the question of the evolution in terms of systemic treatment for metastatic RCC. These are my disclosures. And as Karim mentioned, it is not going to my pocket, but to my institution for research purpose. So what has occurred over the course of the last 2 years, and especially last year, is that we have major change. And I'll first start where we were standing about 1.5 years ago, when at ESMO, we had the new guidelines that were presented with a change in our standard treatment in patients with clear cell RCC treated for intermediate and poor risk disease using the IMDC classification. That is a classification for those of you who are not that used to evaluate that in clinic, which look at four biological features and 2 clinical features to assess the prognosis of our patients. But to put a long story short, 20% of our patients are good prognosis, and the vast majority are either intermediate or poor risk patients. So how things have evolved is the following. The first step that we've seen with clear cell RCC is the change that we've moved away from VEGF single agent using a combination of immune checkpoint. This first step that you're all familiar with and that has changed our practice was based on the data of the CHECKMATE 214 trial, which randomized patients in first-line setting with clear cell RCC, either to standard agent, VEGF single agent sunitinib, it could have been pazopanib, or a combination of PD-1 inhibition, nivolumab, plus CTLA-4 inhibition, so therefore a combination of immune checkpoint with a following treatment with nivolumab single agent after 4 cycles of the combination. And this trial did allow all patients, irrespective of their IMDC risk classification, but the primary endpoint was looking at the intermediate and poor risk population on the rationale that those tumors may be more inflamed, and on data we had with nivolumab single agent that seemed to derive greater benefit in patients with poor risk features. So that trial, when reported, was highly positive in terms of overall survival, clearly changed the dogma, moving away from VEGF single agent with a hazard ratio of 0.63. And here, median overall survival not reached for patients receiving the combination of immune checkpoint, and in the range of 2 years for patients treated with VEGF single agent as first line. On top of that, we also saw a great benefit in terms of response rate. From 27% of patients having partial response or complete response with sunitinib to 42% of patients having objective response with the combination of immune checkpoint. So more patients having a significant tumor shrinkage. And on top of that, and this has really changed the way we speak to our patients, broadly 1 patient out of 10 would achieve complete response. So this led to the approval that I've shown you on the ESMO guidelines. However, what about good risk patients? In this trial, it was allowed to enroll patients with good risk. But if you look at the data, although this is not primary endpoint, this is secondary endpoint and subgroup analysis, those patients with sunitinib had a more tumor shrinkage with sunitinib than nivolumab plus ipilimumab, and a longer time to progression, that in the range of 25 months, so it means 2 years with sunitinib single agent. So those patients with good risk disease clearly derive great benefit from single agent TKI and were therefore not included in this paradigm change we've seen in first line. With regard to toxicity, most of you have now used this combination for those who treat kidney cancer. 1 patient out of 2 may have high-grade toxicity, and in the trial, patient had to discontinue treatment because of toxicity in 20% of case, which is quite high. So what data did we have this year to confirm with longer follow-up this report? We now have, with more than about 3 years follow-up, the update of this study. And to put the long story short, if I walk you on this slide from the right-hand side to the left-hand side, we have the confirmation of overall survival benefit in patients with intermediate and poor. The response rate is the same, 42%. with 11% of our patients being put in complete response, which is, as I was mentioning, a clear change in the way we raise the expectation and also the patient's expectation. And the PFS that is favoring on the Kaplan-Meier the association of nivolumab plus ipilimumab as well now. What about good risk patient? Well, if you look at overall survival, the curves are really close one to another, but still the response rate is higher with sunitinib, and the PFS now is still in favor of sunitinib, although the trend is changing a little. So we didn't change the guidelines with regard to nivolumab plus ipilimumab. It's still indicated in patients with intermediate and poor disease. So the second step, which arrived last year, was the combination of immune checkpoint plus VEGF. I must say that when I was hearing Karim saying it's not because we have two agents that works well that we should combine them, this is what has been done. There was some rationale, and I didn't get into all the phase 1 data. There was a rationale that with VEGF targeting, you actually enhance the ability of your immune cells to get to the tumor cells, and therefore you enhance the infiltration of T effector cell to induce the immune response. So that's a simplistic way of bringing your attention to the fact that those two drugs had a rationale, and the first data that were very appealing were actually initiating patients with bevacizumab, VEGF targeting, and then adding atezolizumab, PD-L1 inhibition. So if you think about guidelines, these are the updated EAU guidelines, and we have now two standards that are available and that are recommended in intermediate and poorest patients, one of which is pembrolizumab, PD-1 inhibitor, plus axitinib, VEGF TKI. And if you pay attention to the IMDC risk group, this combination of axitinib plus pembrolizumab is here in all risk group. So, on which ground were this change made to the guidelines? Well, over the course of last year, we had several trials which reported on this strategy of combining VEGF inhibition plus PD-1 or PD-L1 inhibition. On this slide, I only put the two of them that led to EMA approval. And as I mentioned in the guidelines, only one of them appears as strong recommendation, and I will comment on this point. So the first study, Javelin study, compared PD-L1, avelumab, plus strong VEGF TKI, axitinib, that you know is one of our potent VEGF, against sunitinib, standard of care. And the second one, pembrolizumab, PD-1 inhibition, plus axitinib, the same TKI, against sunitinib. So those two trials has been reported in the New England. To put the long story short, and so that you have a key message, these are the following. The first one is that axitinib plus pembrolizumab demonstrated a high overall survival benefit over active agent sunitinib with a hazard ratio of 0.53. And this study was reported with about 1 year follow-up at the time of first presentation. If you look for the median overall survival, they are not reached in none of the two arms. Second key information, checkpoint inhibitor plus VEGF TKI demonstrate high response rate and higher response rate over sunitinib. So here I put the two studies, the keynote study with the almost 60% response rate versus 35 for sunitinib, and the Javelin study, avelumab plus axitinib, 51% rate over 25. So this study, of course, may have some subtle difference in terms of the patient population enrolled, but if you put the two of them together next to the nivolumab plus ipilimumab data I've shown you, there is a strong signal that having TKI plus PD-1 or PD-L1 reach a higher response rate, and I think it's important in terms of symptom control or rapidly growing disease to have this information in mind. Third information is that because you have a VEGF backbone in those two combinations, axitinib, you are able to control patient with good risk, which may be more driven by the VEGF or angiogenic signature pattern. And this is the avelumab plus axitinib trial, where we can see that there is a significant progression-free survival in favor of the combination of axitinib plus avelumab over sunitinib, irrespective of the IMDC risk classification. Lastly, talking about biomarker. So there was a rationale that PD-L1 positive tumors are more likely to respond to an immune checkpoint. What I'm showing you on this slide is that we see the same magnitude of benefit in patients that are PD-L1 positive than in the ITT, the overall population, because you have the VEGF component in this combination. And I think it's important because we won't see the same way if we were discussing nivolumab plus ipilimumab only. Here, because we have the VEGF, it's very likely that we're able to trigger a more broadened immune response irrespective of the PD-L1 staining in those patients. Last point, for those of you who have treated patients with CKI, if you look at this slide, you'll see, oh, when I add PD-1 on top of a TKI, so here pembrolizumab on top of axitinib, I know those side effects. I know diarrhea, I know hypertension, I know how to manage that. I've done that for 10 years, 15 years. Maybe the liver enzyme increase could be a bit challenging, but this is not frightening as first seen. So if we want to be provocative and if we put the two combination for patients that are either intermediate or poor, you could ask yourself, am I going to start with IO-IO, nivolumab plus ipilimumab, or this new regimen, axitinib plus pembrolizumab? So for nivolumab plus ipilimumab, you have more follow-up. I've shown you the 3-year follow-up update, consistent overall survival benefit. You have a strong complete response rate, 11% of patients, and you have a good quality of life for those who are not having immune-related symptoms or that are properly managed. Although this management is of importance, and I'm sure that you've seen those patients needs to be first promptly identified, promptly managed with discontinuing CTLA-4 component or both components, maybe starting steroid, and sometimes you need the help of other specialties, neurologists, and so on. With regard to immune checkpoint plus VEGF inhibition, we see this very strong overall survival benefit that is very early on, so it's a strong signal with maybe the highest response rate that we've seen in RCC. We also see this long PFS when compared to sunitinib or the combination of even nivolumab plus ipilimumab, although these are not the same trial. And it works in all IMDC risk group, so it's easy. And it's irrespective of PD-L1 staining, so you don't need to ask your pathologist to assess that. And you could tell yourself, okay, the toxicity seems manageable. I think this is a very simplistic way, and there are many caveats that I would like to draw your attention to. The first one is the follow-up. So for the moment, we have a follow-up that is in the range of 1 year for the axitinib plus pembrolizumab combination. Why is it important? Because in the past, short follow-up has been very misleading exactly in this setting. There is a combination that I've not mentioned until now, except for phase 1 data, that is the bevacizumab plus atezolizumab combination. This was among the first, and this one was a combination that has been well assessed in phase 2, then moved to phase 3. My point on this trial is the following. When we saw the first data of the randomized phase 3, this study was designed with a biomarker population, PD-L1 positive, and there, the data were considered as immature, but with a trend that was quite encouraging after 15 months. And in the overall population, it was not easy to say, and the conclusion at that time was data are very immature. Maybe we'll see a trend because, once again, we have a VEGF component here, so maybe the biomarker is not that useful. But these are the final data that were published this last year. And here again, what you see is that the trend that was initially seen in the PD-L1 positive population, as well as in the ITT, is not confirmed with a longer follow-up. So with less than 1 year more follow-up, we lose this, this signal that we had seen initially. So I would really be cautious about early assessment for immune checkpoint combination here. We need more follow-up to be very strong on the magnitude of overall survival benefit. The second question is, are we sure that we have the right and the best combination? So for the moment, axitinib plus pembrolizumab has been approved FDA, EMA approved based on the data that I've shown you. Avelumab plus axitinib has been approved in Europe, however, did not demonstrate an overall survival benefit yet. So it was approved on PFS and response rate benefit. So what about other regimen? And we have now 2 trials that are still pending for readout that also use sunitinib as the comparator, so there will be a cross-comparison trial. One is lenvatinib, potent VEGF plus FGF, that has demonstrated some activity in later line, in combination with everolimus, because at that time it was based on the data in later line in combination with everolimus, but also here in combination with pembrolizumab. And so these data, the clear data, are expected to be presented this year. And it is important to see if the magnitude of benefit we've seen with axitinib, combination-based, is also seen with lenvatinib, for instance. And there are other combinations here, I-stress nivolumab plus cabozantinib. You know cabozantinib, you've used that as a rescue drug in patients that failed 1 prior TKI. Cabozantinib is a very potent drug, but as lenvatinib, it actually has a broad spectrum. And so I think those 2 trials will answer the question on the kind of TKI we should use in combination. Is it a narrow spectrum, pure VEGF, or is it a broad spectrum, such as with cabo or with lenvatinib? So these 2 trials are awaited. The next generation of trial will not use sunitinib as comparator. So the next generation of trial is using nivolumab plus ipilimumab in combination, and this is something we'll look at, of course, as well. The third caveat is toxicity. And I'm sure you've guessed in the way I was presenting things that I would like to see more data, longer-term data, of axitinib-based regimen. Because in practice, what we see is that diarrhea tend to be more difficult to challenge in combination with PD-1 because you may enhance the toxicity, as well as the liver toxicity that can be quite challenging. And if you look in detail, in the keynote trial, you see that you have quite a large number of patients that required treatment discontinuation, or at least one of the 2 components. So you may ask yourself, at a large scale, if I'm withdrawing one of my 2 agents, maybe I won't see the same magnitude of overall survival benefit. And lastly, we don't have head-to-head comparison between nivolumab plus ipilimumab and axitinib plus pembrolizumab. So for the moment, the few data we have are retrospective. This is an American cohort, and it's very few patients. And I'll draw your attention to the fact that I've highlighted TKI plus immune checkpoint have a very high response rate, and this is not what we see in this cohort. The reason for that is that many of those patients actually had bevacizumab plus atezolizumab, so that may explain why the response rate was not that high in this retrospective data set. So to ponder the previous slide, I think I would like to add that we need more follow-up for the TKI plus IO strategy, and that the toxicity need to be addressed in a real-world setting to see if we're doing really better. But the question is not which one of the 2 strategies is the best, it's how we choose within one patient. And so we are at a stage for RCC where we are designing trial with biomarkers that are implemented to define the strategy. And this is a trial that was conducted in France for 2 years, for which patient with upfront metastatic disease. We collected a frozen sample of the primary of one metastatic site so that we could perform gene expression profiling and determine what we call molecular subgroup. It was based on previous work published from Benoit Busling team. And based on this molecular group, either the patients were considered as immune-driven, and the randomization was single-agent immune checkpoint or combination of immune checkpoint, or VEGF-driven. And so this trial will, I think, may not fully answer the question because of the design, but may help to demonstrate that we're able to implement biomarker in routine practice. Another question is, maybe we don't need a combination for everyone. And at this ESMO presented by Oliver Grimm, there was the Titan RCC trial that was presented. It's a trial which enrolled patients in first line and second line, and what is innovative here is the design. You start with single agent nivolumab, single agent PD-1. you assess the patient, and if the patient is in complete response or partial response, you say, okay, single agent works in this patient. I'm going to stick to nivolumab single agent. If the patient is not responding, meaning either stable or progressive disease, you add on the ipilimumab. So the strategy is to plug the second drug to prevent toxicity in those who would not need the second agent. And so this trial actually also allowed to add the ipilimumab early on if the patient was progressing very early after 2 months, or allowed to add the ipilimumab later in a patient who had late progressive disease. Very, very preliminary data have been presented. The key informations are the following. In first line, single agent nivolumab provide a response rate in the range of 28–30%. So that's single agent PD-1. The fact that you add ipilimumab brings on 10% more of response. So you are rescuing 10% of your patient when you add the ipilimumab. So you could tell yourself, oh, okay, so basically I was having 42% response rate, now I'm seeing 37. This is not that bad. But you could also see it the other way around. I think this approach is very informative in patients that may be frail or for which you are not willing to move forward with the combination up front. And ultimately, in second line, we see the same pattern. We add 10% of rescue with ipilimumab. This is not something we can do in Europe because of the lack of reimbursement of ipilimumab in second line, but it is of interest to have this information. So maybe we don't need combination in all our patients. The question will be how we decide this, and this is where the previous trial, the Bionic trial, where you have this molecular classification upfront, may help you to define if you need the combination or not. And of course, if we change the first line, it's going to change all the algorithm. So if we put nivolumab plus ipilimumab in first line, your patient never received VEGF. So you can use any one of them. You name it, sunitinib, pazopanib, axitinib, cabozantinib. But in a patient who had a combination with a TKI, you're therefore in a TKI refractory setting, so you will be willing to use another TKI, and it's very likely that cabozantinib may be the agent you want to use in this setting because it's a drug that has been approved in a VEGF refractory setting. It also stressed the information that we've used 2 classes of drug, and we may want to use another strategy. So the field is moving forward with testing new hypotheses and new target. And the one I would like to highlight for you are the following. The HIF inhibition. So basically, for the moment, we had inhibition of VEGF axis through either VEGF or VEGF receptor. But because we are now able to target the HIF pathway itself, I think we should be paying attention to the HIF inhibitors that are under development because these drugs are, in terms of safety, seems to be manageable, and we need to see how they perform in combination with maybe PD-1 or CTLA-4 combination strategy. The second class of drug that we should pay attention with is the one that is targeting the metabolism. And this is not specific to clear cell. This is something we should consider as well in papillary RCC. So basically, we do know that in RCC, from the TCGA data, there is a strong activation of specific tumor metabolism that involve the mitochondria. And here, we're able to block the glutaminase pathway through glutaminase inhibitor. This is a work ongoing, and we'll expect to have first results very soon this year. And the third block is the one you know, the interaction with the immune environment. So for the moment, we've had a PD-1 CTLA-4 targeting, but as you're very familiar that there are other immune checkpoints that are being investigated. IL-10, PEG-IL-10, for instance, or PEG-IL-2 are some of the drugs that we should have in mind. So to conclude, I think that the good news is that we've clearly changed the overall survival of our patient, but also the strategy in RCC. We've moved away from single agent to combination on the ground of great overall survival benefit and response rate benefit. We're not yet there in terms of how we should select within our patient, and this is where academic research has to be involved. We haven't integrated this change in our overall algorithm, and we need to define what are the optimal subsequent line. And there are many open questions. We had the same in the era of single-agent TKI, which is how long shall we treat our patient, especially if they're great responders? Do we need to go for a doublet upfront, or should we use a de-escalation strategy and just add on in patients that are not responding? And ultimately, we need new agent because although the overall survival benefit has so much improved, we still have a room for improvement there. And I thank you very much for your attention.